Bangladesh. With a population of more than 158 million people, it is one of the world's poorest countries. An estimated 40% of its population live on less than $1 a day, and over the past 3 decades, Bangladesh has experienced one of the highest urban population growths in the world. An estimated 37% of Dhaka's residents live in overcrowded slums, often without access to safe drinking water or adequate nutrition, and without primary healthcare services. The picture is similar across the entire country.
Today, Bangladesh, we know that Dhaka is one of the fastest growing city in the world. And by 2050, I think it will be the 3rd largest city in the whole world. The major challenge will be facing the migration from rural to urban. People who come to Dhaka because of the jobs, because of their livelihoods, and this migration is putting a huge threat in terms of infrastructure and particularly on health issues. And in the slum areas, the major challenge is the infrastructure. We do not have any infrastructure. The slums are not even recognized. They do not have access to primary health care. They do not have access to water, sanitation. And this poses a major threat not only to the slum people, it poses a major threat to the country's development as a whole.
And yet, amongst all this, the country has made enormous advances in life expectancy, child health, literacy, and disaster preparedness. Over the last 40 years, the fertility rate has been dramatically reduced, and high levels of immunisation coverage have been achieved, which, in turn, has led to unprecedented reductions in maternal and child mortality. It's even on track to achieve MDG 5 to improve maternal health.
Every mother of the country, I think, every man or woman know the vaccination program. We get a success story by combined effort of the award people and also the activity from the government side and the contribution of the voluntary.
Bangladesh's basic population and health indicators are on a par with or better than its neighbours. These achievements have been made with low total health expenditure and even lower health expenditure financed by the public sector. This means that Bangladesh has managed to achieve relatively good health at a low cost over the last 3 to 4 decades, and is featured in the recently published Good Health at Low Cost book, edited by the London School of Hygiene and Tropical Medicine and funded by the Rockefeller Foundation.
In Bangladesh, the rate of home-based delivery continued to be extremely high, over 80%, and international programs, donor assistance has not changed that. People continue to deliver at home with traditional birth assistance, and this is the cultural norm. However, what has changed is access to emergency obstetric care, which is now increasingly better. This is due to better facilities for secondary care, better practices, better treatment protocols, better quality, and better roads. So people, when they need to have access to emergency obstetric care, they're able to obtain this care. This has led to dramatic improvements in outcomes. So women are much less likely to die in childbirth than they were 20 years ago.
But how did Bangladesh do it? What factors were at play? And is there anything the rest of the world can learn from what has become known as the Bangladesh miracle?
As a citizen of the country, we can feel proud in the South Asia, and we are at par or outshine the neighboring countries in terms of the declining fertility, in reducing maternal mortality and child mortality, because of the right steps taken by each successive government right from the 70s.
Bangladesh has an amazingly resilient health system that has transcended poverty over a long period of time, and it has also survived all political changes since independence over the last 40 years. Interestingly, it has all the health sector successes were achieved much ahead of economic development of the country. This is what we call Bangladesh miracle.
After a violent and bloody war of liberation, Bangladesh achieved its independence in 1971, but it came at a price.
The infrastructures were already in tatters because of the long war throughout the period of 1971. Roads, bridges, river communication, rail communication, everything was topsy-turvy.
Other challenges facing the new nation were frequent natural disasters, including seasonal flooding, cyclones, and devastating famines such as that of 1974. Mortality rates were high, life expectancy and literacy were low, and poverty was rampant. The fledgling government also suffered from widespread inefficiencies.
On the political side, this was a provincial government assuming the role of a national government. So everybody suffered from inexperience.
Yet in 1972, a political commitment to health was enshrined in the new constitution, and since then, the health of the country's population has been a political priority.
Bangladesh has transcended all political changes over time. Bangladesh health system has transcended poverty for a prolonged period of time.
Bangladesh has been lucky in being able to maintain reasonable continuity of policy and programs irrespective of political changes throughout the period. Whether it was elected government or non-elected government, or whether a party which was elected once was defeated in the next election, that has been the tradition in Bangladesh. So the basic continuity in programs, in the mode of delivery of service, and in financing mode, in all these three categories there have been continuity.
In essence, politicians and their many unseen but effective civil servants and technocrats have become key stakeholders in the country's health system, playing an undoubtedly critical role in transforming the health of their population.
I think they play a vital role to develop our health sector, because now the technocrat, like any technical person working in the health sector, they play, now they are the policymaker.
One thing we identified in all of the countries was the existence of very able technical people who were able to put in place the right policies and to ensure that those were implemented down to the local level. But I think it's also important to recognise that they need political backing, that they can't do everything on their own, and therefore a political level that gives priority to health is absolutely critical as well.
For Bangladesh, getting health services down to the local level became a priority.
Population growth was a key problem that the government had to face. And along with that, there was a clear realization that this was a rural population where services had to be delivered at the doorstep. So it was the government's decision, partly out of political conviction and partly out of historical necessity, to provide primary healthcare services in the rural areas.
During the 1970s, the government developed a public health system along the Health for All model, with a nationwide network of hospitals, health complexes, family welfare centres, sub-centres and outreach clinics. At the same time, a parallel network of family planning and maternal and child welfare centres was established. In fact, the Bangladesh government was one of the first developing countries to strongly endorse a national family planning programme.
What we've seen through programs that were implemented over the course of the last 35, 40 years is that total fertility rate has gone from about 6.3 births per woman to a much lower and more rational 2.7 births per woman. And it's been done through really the healthcare system, which has had sort of the unique structure in Bangladesh of having a Ministry of Health and Family Welfare that's divided into two wings, one that focuses on health services and one that focuses almost exclusively on family planning. Through this Directorate General for Family Planning, women from the villages were trained, so not medical doctors and not nurses, were trained to go door to door delivering family planning services and really educating women about their ability to control when they would reproduce. And this enabled this amazing miracle to happen in Bangladesh.
Empowering women at the village and community level was to become part of a strong political commitment in Bangladesh. As a result, an army of health assistants and family welfare assistants have been trained to carry out health promotion and disease prevention activities, from contraception advice to the importance of personal hygiene. They can also deliver medicine, report early signs of infectious diseases, and register births and deaths.
Government of Bangladesh was very smart in making the decision in the 70s to recruit the female field workers to work on the family planning front. And they recruited over 20,000 female family welfare workers who are high school passed. And in a time when there are not many girls available who are high school passed. So that was a bold decision made by the government of Bangladesh.
The community health workers, they are the backbone of the Bangladesh healthcare system. They really are. Those ladies, the family welfare assistants, and the men who are the health assistants, they're out there every day in the fields where it's hot, teaching people and empowering people how to take care of themselves and their families.
আমার কাছে খুবই গুরুত্বপূর্ণ মনে হয়, যেমন আমি একজন মা স্বাভাবিক মা হবে, একটা সুস্থ মা যেন সুস্থ শিশু প্রসব করতে পারে, এই বিষয়ে আমি গুরুত্ব দিয়ে আমি নিজের মতো করে আর কি কাজ করার চেষ্টা করি এবং আমি প্রত্যাশা রাখি করতে পারবো।
Whilst the success of government intervention policies certainly needed the impetus of committed community health workers, civil servants and politicians, the coverage of the policies would not have been as widespread in terms of geography and outreach to disadvantaged communities were it not for additional non-state resources and non-government organisations. Large NGOs have high levels of political autonomy and flexibility, and they have been able to play an important role in improving health as well as in reaching populations that have been excluded because of isolation, stigma or lack of resources.
Bangladesh is a developing country. For this reason, the government recognized the NGOs, and people also recognize the NGOs and the activity of the NGOs. And I think it is a very, very positive sign for the country.
The government recognizes that there's this large population and there's no way that one public health system could meet the needs of everyone in the country. And then the NGOs recognize that they do need to follow the edicts that are given from the Ministry of Health and Family Welfare and be compliant with policy in Bangladesh. And in the best of NGOs, there's great partnership there.
Some 2,000 NGOs work in Bangladesh, including some of the largest and most reputable in the world. BRAC, for example, was created in the early 70s, after the War of Liberation, to deal with small-scale relief efforts. Today, it has grown into the largest NGO in the world, and its scope has widened to include multi-sector programs for the poor and landless, including health and education.
BRAC started with the whole issue of poverty aversion and empowering the poor. That's the BRAC's overall mission. BRAC always believed that they work with the national government. In national government's priority is BRAC given the first priority. Like in the 70s and 80s, the family planning program, the immunization program. So BRAC partnered with the national government in addressing those national issues, but learn from the communities how to do it. So we work at the community level, we involve our workers, community volunteers and our workers at the community level with from the household to the community leaders, earn the trust of the people, and the trust is our capital.
BRAC's 64,000 village health workers touch the lives of more than 110 million people, and all this without drawing on public facilities, which does not weaken capacity in the public sector. Since 2006, BRAC has been using trained birth attendants, health workers and volunteers to deliver maternal, neonatal and child health care in urban slums.
So BRAC's vision that whatever we learn from the community, test it, prove evidence that it works, and if proven evidence is there, then go to scale.
Learning from the work in the community, testing and then scaling up has led to the development and adaptation of innovative low-cost technologies and proven interventions. With a history going back before the War of Liberation, the International Centre for Diarrheal Disease Research, ICDDRB, has become a global leader in population and health research, with a worldwide reputation for developing innovative low-cost technologies that have led to improvements in health. ICDDRB is perhaps best known for its groundbreaking work on oral rehydration solution for the treatment of cholera.
ORS is oral rehydration solution. It's a fistful of sugar and a pinch of salt mixed in a liter of water. So you can buy it now in Bangladesh. It's sold everywhere in packets, and you can mix that with clean drinking water. ORS came into existence and was invented during a huge famine and crisis and cholera outbreak in the country through the NGOs, with the support of the government and the approval of the government, with ICDDRB as a research partner and with BRAC then as the delivery partner. Someone in each household was taught how to do this, and that's really the first great example of innovation in Bangladesh.
More recently, ICDDRB is credited with the introduction of zinc for the treatment of childhood diarrhea. Delivered in a soluble tablet form, this low-cost, innovative solution was developed and scaled up in Bangladesh and is now being used in many other developing countries.
If we look at the Copenhagen Convention, scaling up zinc and vitamin A, these are the #1 and #2 low-cost, big payback health solutions on the planet.
No one can argue that all of Bangladesh's health challenges have been met, nor will be met in the future. However, some key players within Bangladesh see universal coverage as a vital and attainable goal.
We talk a lot about a whole of government, whole of society approach, and I think that for many parts of health in Bangladesh, this exists. It's commitment to health that transcends political party. What I also think can most readily be translated from Bangladesh is that you don't need a doctor or a nurse to help people learn how to manage their chronic conditions.
Whatever the future holds, Bangladesh has shown and can build on key successes in the past, and the hope is that they can continue to deliver good health at low cost for their people.